All right, so I'm going to be talking about some work we've done with colleagues at the World Health Organization looking at health financing in fragile and conflict-affected states. As Awad explained, and I think many people in the room are well aware, conflict has been expanding and the number of people affected have been expanding. And the focus for populations in extreme poverty is now coalescing in these areas of fragility and conflict-affected states. And at the same time, the health indicators and the indicators of health need are also not going to be addressed unless we focus on these areas. So this is just general background about why we focus on this. We also recognise the impact of conflict specifically on mortality. But studies have also demonstrated that fragile, conflict-affected states are not receiving the same health aid that more stable settings are. And again, I think we all understand intuitively why that might be, but what that means is there's a mismatch to need. So if we want to address the Sustainable Development Goals, clearly these are contexts we have to understand, and we have to understand what works, what doesn't work there. And that's what this piece of work is about. So hopefully all of you are already converts to the importance of health financing, so we don't have to belabor the first point. Nothing happens in a health system unless resources are flowing appropriately. So our interest then was on developing technical guidance which is adapted to these contexts. So WHO has developed a number of tools in recent years, for example, on health financing diagnostics. But also looking at how to develop national health financing strategies. And the question is, how well adapted are they to these settings? And that's what we're hoping to discuss with you today and get your feedback. So we had a series of meetings with experts, and we also looked at the literature. So ReBUILD did a literature review in 2012, health financing, what do we know and what are the gaps, or something along those lines. And what we did this year was to update that. And so this piece of work, which is still in process, but which we'll be sharing with you today, is based on the literature, also the consultations, but really also the experience of the team. And so meetings like this are a very good occasion to get your inputs and your insights. So many of you will be aware that there's a huge literature around typologies. What is fragility? How do we recognise it? What are the FCAS countries? Different organisations have different definitions. So I'm not going to run you through all that, you'll be relieved to know, but really just to say that the literature does tend to coalesce around three different domains. So there's a recognition that capacity gaps is one aspect, so that's the ability to deliver core services, and of course that's very important when we think about health systems. There's the issue of legitimacy gaps, so governments that are unrecognised or contested and what that means for delivery of social services and obviously wider public administration. And then, of course, the issue of security. And this is an old paper, and I'm not saying the classification is correct, but what's interesting to note is that some countries might face one type of deficit, some might face two, and right in the middle of your diagram, of course, you've got countries that may be affected by all of those, and those are particularly acute in terms of the challenges that they face. So in terms of what that means for the health sector, I think it's fairly obvious that all of your building blocks in these contexts are going to be struggling. Service provision, gaps, and particularly it tends to create an inequitable health system. So I'm not going to run through all of these because I think they're very well known. What we did in this paper then is to try and focus very specifically on the health financing side. And we took the framework which WHO uses or has developed, looking at the kind of primary activities for health financing, so revenue raising, pooling, purchasing and benefits packages, and looked at the literature on those, but also then what is known about fragile conflict-affected settings in terms of the intermediate objectives, so your equitable resource allocation, efficient provision, accountability, and of course also the goals, so around utilisation related to need, financial protection, These expand every time you look at them: equity in finance and quality of care. So we keep finding things we've got to add into the boxes. So what we did was just to try and map what are the challenges in fragile settings. I'm using fragile as shorthand because it's very long to say fragile and conflict-affected settings each time. But that whole group. And also, what are the policy innovations? So what's been tried out and how well has it worked? And what are the gaps? And I've got a number of these which I'll try and move through fairly quickly. But basically, this is just a summary of some of the overall evidence. On the left-hand side are really the kind of features that we want to see in health financing systems. So, for example, for revenue raising and pooling, what ideally we want to see is the predominant flows coming from public mandatory sources, of course, predictability and stability of funds. We're looking for redistribution. We're looking for complementary funding sources, trying to address issues of fragmentation and trying to simplify financing flows. And that's something you would look at in any context. But what does the evidence tell us about the fragile states in relation to those desirable features? And that's really what we have in the middle column. And you'll be unsurprised to know that, generally speaking, there's low funding in these areas. Although, having said that, there's quite a lot of countries where there is, in fact, in the more middle-income shock-affected ones, you can quite sometimes have high funding but badly distributed and badly used in some cases as well. Public funding, which is a source which is important to a lot of the other functions, is often low, and that's driven by low GDP growth, also lower levels of taxation than for other settings, but also sometimes non-prioritisation. And of course, where you have multiple authorities collecting revenues, territorial control issues, these are all things that feed into that. Conflict itself is another depressor of health expenditure, while also raising needs. And typically we find a higher dependence on external financing, which means that there are issues around the stability of payments, lack of predictability, often a lack of alignment with public priorities. But it does vary by country. So external studies of aid support have also tried to identify what are the kind of countries that get more support, and have concluded, for example, that countries with political gridlock, flawed elections or economic decline are less likely to be externally supported, for example, compared with others that have external interventions. When we looked at the data for the FCAS group as a whole, we found that there was a higher external finance for the middle-income group, but not for the low-income group, compared to the non-fragile ones. So we also were interested to look at this assumption that you have a period of a shock and external dependence and then a trajectory of moving away from that. And we found that wasn't well described in the literature. It's actually not clear what the common path of sort of movement away from conflict and crisis is in terms of this external dependence. Financing can be both too low for needs but also too high for absorptive capacity. And that's another phenomenon that is quite common in a number of countries. When you look at out-of-pocket payments, obviously typically those tend to be higher, and I'll show you that there's quite often a bit of a sort of dance that happens between public finance and out-of-pocket payment. And of course there are issues around trust, which affects ability to pool and creates more fragmentation. And commonly we get a segmentation between humanitarian interventions and the populations which are protected through those mechanisms and the host community. So in terms of what's been done about that, so if you look at the right-hand column, there's a lot of literature and indeed interventions which are focused on aid, pooling and coordination, still with major challenges, as I think we'll discuss today. There's also been a lot of attempts to address this financial access barriers, so user fee exemptions, health equity funds, health insurance experiments, demand-side financing, and so there's I must stop hitting that, sorry. There's quite a lot of documentation around that. And in the humanitarian settings, more focus on things like cash and card-based mobile payments. At the same time, there are a number of gap areas that are not well described, so particularly around integration of different strategies to increase access, for example, and also, still issues around better domestic resource mobilisation and more predictable, harmonised external finance. So while there's a big literature, we haven't solved all those problems. Just to show you some of the variation that you find in this group, you can see that the group of fragile and conflict-affected states is incredibly varied in terms of the types of countries, but also in terms of their sort of performance on these various health financing indicators. So this one is just looking at general government expenditure. You can see that you can't see here because we haven't shown the figures, but there is a significant difference between the FCAS countries and non-FCAS. So typically they're allocating less money from government to health financing. But this is actually driven by middle-income country differences. So in the low-income countries, there's no significant difference. So that suggests low-income countries are still attempting to cover their population, of course, with a smaller base, but maybe you're seeing the effects of some of these shocks happening more at the middle-income country level. Equally, when you look at out-of-pocket payments, well, one of the striking things is, again, the diversity, but also the fact that very few of them are under the 20% line. So the sort of WHO norm that you're aiming for is to keep your out-of-pocket payments under 20% of your total health expenditure. And you can see that only a tiny handful of countries at the top are managing that. This is, with the latest data. There is a significant difference. And in this case, it's in the low-income group, but no significance in out-of-pocket payment for the middle-income countries, which maybe suggests that those are somehow able to protect their populations through other mechanisms, even when they're affected by, shocks and so on. Just to illustrate this point, that when you look at it, it's often more interesting to take individual case countries and follow what happens through time. And you can see here the effect of shocks on public expenditure and out-of-pocket payment. And this is Xavier Model, a colleague who produced this at our EMERA consultation. And I think it shows the picture very clearly. So while the overall financing of healthcare isn't significantly different between FCAS and non-FCAS countries, when you look at the composition, that's often where you see the change happening. And in this case, you've got high public expenditure and low out-of-pocket payment, and then you've got two shocks, an insurgency and then an oil price shock. And in both cases, what's happening is public expenditure is plummeting and the household payments are taking up the slack. And so I think that illustrates the fact that, well, as we know, you need to watch the composition and not just the overall expenditure. So this happens in other settings as well, but of course these countries are particularly shock affected. So moving on to purchasing, the features we want to see are around allocations of resources based on need, around moving away from line item budgets, but also controlling overall expenditure, trying to link activity and financing data. In contrast, what you typically see in many of these countries is multiple purchases, quite fragmented often, difficulty of getting data on population needs, and a predominance in terms of payment methods around fee-for-service, with some degree of often underfunded budgets, and a high dependence on user fees and then different forms of contracting in the humanitarian sector. So there's often a lack of confidence in government and channeling of funding to NGOs, which can lead to a patchy provision and sometimes higher costs. Obviously, there are issues around data on payments and outcomes and a complex remuneration structure for providers, which means that accountability can be quite weak or divided. So in that context, what's been tried? Most of the literature is focused on two areas, and we're going to be discussing both of those in our panel today. One is around contracting in and out of services, and the other is around performance-based financing. There's much less written about this issue of trying to harmonise purchasing arrangements generally, and indeed trying to bring together the humanitarian and development approaches into a more sort of harmonised approach. And then finally, on the benefits package, we're looking ideally for a very clear set of entitlements, a high degree of population understanding of what those entitlements are, and those entitlements being well aligned with the provider payment systems. So that's our goal. But then in practice, we often find entitlements are very unclear. In fact, the whole concept of entitlement in many of these countries seems somewhat paradoxical, because people have sometimes quite low expectations of public, public mandate and provision and so on. Often low awareness. Healthcare packages are sometimes defined. In fact, quite a lot of the work that's been done on essential healthcare packages has been done in fragile settings. But nevertheless, you can often get, lack of clarity around those. And then often this fragmented provision that we know about with funding of vertical programs, sometimes focusing resources on areas that are not public priority. And clearly service provision capacity is typically disrupted. That's almost a definition of the context. And again, this issue of parallel services. So what's been done is quite a lot of work, as I said, around essential healthcare packages, and I think we're going to pick up some of that in our panel on Afghanistan. But not very much on quality of care, and also the need to adapt more our tools like costing to these very dynamic settings. In relation to the UHC objectives, we sometimes see resources captured, not going to highest need populations. We often see problems around inefficiency which relate to the fact that funding, critical elements of funding are missing. Sometimes you've got a lot of funding going to some high-tech equipment through one channel, but then you haven't got your basics, your basic drugs or supplies at the facility level. So that means the whole system doesn't work. So commonly problems of that nature, and also weak accountability. And ultimately that feeds through to the goals. So we know that there's inequitable access in most of these areas. Underconsumption by the poor is a severe problem, often including in urban areas, and with the fact that populations are moving around, not well covered by the facilities. Commonly regressive financing, particularly through the out-of-pocket payment mechanisms, and lower financial protection. And we particularly in our data sort of seem to see that more in, not that it's higher levels of lower financial protection, but more effective being an FCAS country, again, at the middle income country level, whereas the low income countries have low financial protection across the board, FCAS or non. And as we're saying, quality of care poorly regulated. And there's some cross-cutting themes that feed into those. So public financial management is very much sort of in vogue at the moment, but clearly that capacity is an issue in many of these settings. Also, the whole health financing structures, institutions typically have weak capacity. At the same time, there is a literature around the kind of window of opportunity concept, which is that after a shock comes an opportunity for reform, comes an opportunity for strengthening, and there are some cases that support that, although it's clearly not an automatic thing. Again, just to show you quickly the UHC coverage index for the FCAS countries, again a variation in performance, no significant difference between FCAS and non for the low income countries, but again a significant difference at the middle income countries. So we're seeing a little bit of a trend here, I think, and we look forward to your ideas on these. Just reflecting on the overall literature, there's a very substantial one around good aid practices. So around being able to make longer term commitments, for example, around context sensitivity, trying to support government stewardship and capacity even in difficult situations, and also avoiding negative practices like fostering brain drain and so on. Harmonisation, integration, working more closely between formal systems and communities, an emphasis on agile monitoring, recognising that the data capture and data systems have to be more flexible in these settings. And then also thinking about political economy and how we can work in a more politically, economically sensitive way. And that's not a phrase, I've just made that up. Of course, being able to work across borders as well. So many of these have contested borders, so working in a regional way, how do you take advantage of windows of opportunity? And also recognising that sometimes it's about preventing collapse, and that can be a legitimate action in some of these settings. So just to pick up a few observations on the literature that we saw, one is that some countries are very well represented in it and lots of other FCAS ones aren't. So Afghanistan in particular had the highest number of studies. We can ask our Afghan panel to reflect on that. Some topics are very well covered, others are very neglected. And overall, of course, there's an issue about study quality, not surprisingly, because these are difficult contexts for research. And we think some of the bigger projectized interventions get documented, but some of the smaller, more local, homegrown innovations are not being documented. So there's a bias in the literature. And as I said, there's also a siloed literature between humanitarian and development sectors. We've highlighted, I'm not going to go through these because I've been given a sign by our chairman, but some areas which could do with more research. And so moving to the conclusions, one is really around this heterogeneity. So it does mean that we end up struggling with general lessons for FCAS countries because they don't sit together in one big pool and all of the typologies are contentious. But what we recognise is there is quite a performance variation there. That many of the low-income countries seem to be sharing features with other non-FCAS low-income countries, and that maybe some of the shocks are more evident in terms of a changed behaviour or challenge pattern in the middle-income countries. We think that the principles for health financing reforms that WHO has produced are even more relevant in these settings. You didn't look at any of them and think they didn't apply. They, in fact, apply more acutely, because the problems are even greater around fragmentation, complexity, volatility, etc. And we're also seeing a merger, I think, of some lessons coming from the conflict-affected and humanitarian setting with more sort of fragile development contexts, because many of these conflicts are now protracted and complex. So some of the innovations around insurance and contracting and so on apply across the board to both. In terms of areas to pursue more, we've highlighted some of those, including more tailored health system assessments, looking at these contexts. So I said more understanding of politically astute interventions. We're talking about often very politicised arenas. And developing some tools which help us to react better to crisis. So some of these basic packages need to be kind of ready to go, having more simple systems for tracking expenditures and resource flows. I leave with you a few references. Thank you very much.
Well, thank you very much.